may I invite the next speaker, Dr. Rupjyoti Talukdar, and he's going to talk on pancreas and gut microbiota crosstalk. Dr. Talukdar is director of Pancreatology at the famous Asian Institute of Gastroenterology Hospitals, Hyderabad, and he's worked primarily on pancreatitis, pancreas inflammation, and the microbiome. He's had many lectures delivered across the world and has many prestigious fellowships and research grants. So over to you, Dr. Talukdar, please.
Thank you, sir, for that kind introduction. And let me begin by thanking Professor Ganguly, Dr. Nirja, and the Foundation for having me here. And it's a great privilege to be amidst scientists, and especially I'm very happy that I can see lots of young minds who can get stimulated from these lectures and maybe carry forward. So I thought the talk duration was for 20 minutes, but anyway, I'll try to finish off early. Microbiota has been there since evolution, since 4.5 billion years since the first life developed. It has been there, and when humans evolved in Africa, the microbiota also migrated to the whole world. And then based on the diet, the clinical, the environmental factors, they took the shape of the native microbiota of an individual state. So now till a few years back, it was usually believed that the viscera were sterile. The solid organs did not have any organism. But recent studies have actually shown that there are bacteria in the pancreas, and that could migrate to the pancreas from the duodenum. It's not working anyway. It can migrate from the duodenum to the pancreas and harbor there, and has lots of metabolic and protective function. I don't have time to go into the details, but there are two studies which have actually shown there are bacteria, both gram-positive and gram-negative, in the pancreas, and they have something called ori, calcium channels, which produces or secretes cramp, and then that can protect or shape the gut microbiota. Same thing happens with beta cells. But as scientists and clinicians, we'd be more interested to know the crimes, the diseases. So since this is a mixed audience, let's just tell you what are the pancreatic diseases that we commonly encounter. The pancreas, as you all know, is the organ behind the stomach that produces insulin and lots of digestive enzyme. And the most common disease that we encounter is called acute pancreatitis, resulting from alcohol, excess alcohol, smoking, gallstones, and things like that. And it's a very rapid inflammation. Begins in the acinar cell, causes inflammation, and eventually a small proportion would go into organ failure, necrosis, and infection. Chronic pancreatitis, in contrast, is a chronic disease, slowly progressive, may result from acute pancreatitis, and there will be diabetes, there will be recurrent pain and stone formation in the pancreas. And of course, pancreatic cancer, all of you know. So let's see what happens to the microbiota in patients with acute pancreatitis. Several studies, clinical studies, animal studies, and there are several reports of dysbiosis in the intestine, and they have shown lots of correlation with the disease severity. But the problem with acute pancreatitis is there is a common habit among practitioners, even though it is not recommended in any guidelines, to start antibiotics from day one, starts PPI from day one. So we do not really know it's a disease effect or the effect of antibiotics. So I'll stop on acute pancreatitis at this point on the bacteria. But something interesting that we found recently was many of these patients, actually, if you see, this is a necrotic tissue and that can get infected. And in spite of antibiotics, after infection, they do not do well. So what we thought of looking at the fungome. We did a IT as sequencing, and to our surprise, usually in clinical practice from the microbiology department, we often hear about Candida auris and some of the other Candida. But when we see the sequence data, it was surprising to see a whole gamut of organisms, a huge proportion by Aspergillus, Malassezia, Schizophilium, Wallemia, and several. So this was in the fluid of the drain. When we drained those fluid during endoscopic drainage or BCD, we found that. Then we also thought, why don't we look at the stool fungal dysbiosis? And there we could see, again, a host of changes, with Aspergillus being the maximum. And then we also looked at the circulating fungome. And what we see here is, again, there is a trend of whatever was seen in the stool was also seen in the blood and also in the wall of necrosis or the necrotic fluid. So what could be the reason? That could be translocation, and that's where we looked at the gut barrier, and there was significant alteration in the gut barrier permeability. So here it appears that the inflammation and probably the use of antibiotics, which is initially unjustified, that is causing a change in the fungome, and that is translocated into the organism, eventually leading to worse prognosis in the patient. Now let's quickly go to chronic pancreatitis. Again, there were several studies earlier that had shown small intestinal bacterial overgrowth, and we do see it often, especially in the patients with diabetes, but it was not very clearly defined what kind of organism. And that is where we conducted the first study where we could show that there was dysbiosis in patients with chronic pancreatitis. And when we looked at the phenotype of the disease, patients with without diabetes, if we see here, so there is a significant gradient of the organism Faecalibacterium prosnitsia, and also we found in Ruminococcus bromai. And the patient who had pancreatitis with diabetes had a most significant reduction in Faecalibacterium. And we also then looked at the metabolic pathways within the gut flora. The LPS synthetic pathways were significantly enriched, and there was a parallel increase in the plasma endotoxin. Again, this is common sense. If there is more LPS in the intestine, there would be more translocation, more endotoxin. And that actually correlated significantly with blood glucose. So this kind of gives a signal that in chronic pancreatitis, dysbiosis could be causally related to the development or progression to diabetes. And after that, there has been several studies which had similar results. The basic summary of all these studies is there is altered bacteroides, firmicutes, altered diversity, and reduced butyrate producers, which are responsible for maintenance of the gut barrier permeability. And then that was followed by another bigger study, Pan-India samples, 250 patients. And here also, we could actually show that there was gut barrier permeability loss, which we had hypothesized in the previous studies. And more importantly, there was significant change in metabolites, because the gut microbiota do not work by itself. It works by producing or interacting with metabolites. And this is where we could see that several amino acid and other metabolite pathways were altered in the patients who had chronic pancreatitis with diabetes compared to the controls. And I'll not take you through this complex network plot, but to summarize that, we found significant positive correlation of alanine, which is known to produce or improve insulin secretion with Bacteroides vulgatus and Ruminococcus. And same thing happened with myoinositol, which is again responsible for or contributes to insulin metabolism. So this again shows that kind of closes the loop, that dysbiosis, altered barrier, reduction in the butyrate producers, contributing to diabetes through metabolomic alterations. Now, what about cancer? Again, these are not our studies, but well-quoted studies from the West that has shown that there is significant dysbiosis in patients with pancreatic cancer. And this is a mouse model study that showed that ablation of the microbiota protects against the pre-invasive and invasive pancreatic ductal adenocarcinoma. Again, endogenous microbiota was shown to promote immunosuppression that promotes the progression of the cancer. And this was actually supplemented by this very good quality clinical study where two cohorts from MD Anderson and Johns Hopkins were used, and they divided the microbiota based on the survival. The patients who had a good microbiota had a longer survival compared to the patients who had a bad microbiota. And then they could show that the long-term survivors actually had a higher tumor microbial diversity and immunoactivation. And immunoactivation is supposed to cause the death of the cancer cell, the same concept of immunotherapy, PD-L1 medications. And again, fecal microbial transplant could modulate the tumor immunosuppression and growth. So there is kind of an important signal. And then this study actually also showed that there was alteration in the fungome. There was a change in the fungal diversity. The gut and the pancreatic cancer fungome were found to be similar, but there was a significant diversity, beta diversity in the fungal metabolism, which means that even though the organisms are the same or similar, there are a difference in the metabolomic profile. Now the universal debate remains. Whatever I had shown, are they just association, cause, effect, or silent bystander? So in most of the conditions, probably it's difficult to say, maybe a silent bystander, but there are few data. So I was talking about acute pancreatitis. In clinical studies, it's very difficult to tell because there are many other confounders like antibiotics, PPIs, and NJ feeding. But what about clinical experimental work? So this is some work going on in our lab So where we induced acute pancreatitis in mouse models with L-arginine model, and L-arginine is a very severe form of very rapid pancreatitis. So what we saw here, when we dissected the pancreas on a daily basis, there was significant tissue destruction after day 1, and there was gradually there was recovery. And there was a parallel increase in the change in the gut permeability, as shown by the zona occludens expression in the intestinal cells. So you could see there was gradual decrease in the permeability, and it was maximum in day 2, day 3 area. That was further confirmed by immunohistochemistry for occludin proteins, and also for the passage of mannitol. And again, this is the important proof that there is actually loss of the gap junctions here. You don't see this black patch, which is a gap junction, and maximum was seen in day 3. And that also correlated to the intestinal inflammation TLR4 mRNA expression on day 2. And when we looked at the microbiota in this, the peak dysbiosis was seen on day 3, day 4. So this kind of gives us a signal that intestinal inflammation and barrier dysfunction comes first, and that is followed by the peak microbial dysbiosis. But this has to be proven in the humans for thinking of any therapeutic intervention. Now, what about chronic pancreatitis? I think this is somewhere we have some lead that in chronic pancreatitis, dysbiosis and the disease of diabetes is not one-way traffic. It's bilateral. So it begins with chronic pancreatitis and exocrine insufficiency, where there is fat maldigestion, and fat maldigestion can cause gut microbial dysbiosis. And once there is dysbiosis, as we had shown in our studies, there will be gut barrier dysfunction, endotoxemia translocation happens. Again, we have shown that. Plasma endotoxemia can cause beta cell dysfunction. That is very well proven through TLR and NF-kappa-B pathways. And that also leads to pancreatic inflammation, which further leads to dysbiosis. So this is kind of a vicious cycle that goes on. And if we have to treat diabetes or the inflammation in this disease, I guess we have to cut that cycle, not just give target on one side with probiotics or fecal transplantation. So it has to be a two-way process. And again, in fungal dysbiosis and cancer, again, these studies have shown, this is the same study where I had talked about the fungal dysbiosis. What the researchers had done was they treated orthotopic cancer models with different fungi. But out of that, only Malassezia globosa that resulted in an increase in the tumor growth, which means that specifically Malassezia globosa has something to do with promoting the tumor. And in the human counterpart, there is something called a mannose-binding lectin. And when mannose-binding lectin was less, those were the patients who survived longer. So making 2 + 2 = 4, what the hypothesis that was set in that fungal dysbiosis will cause translocation of several organisms, but most importantly, Malassezia. And Malassezia can promote the mannose-binding lectin, which activates the complement pathway, and that's how tumor growth happens. So this is probably a cause-effect relationship that Malassezia can lead to promotion or growth of pancreatic cancer. And this is a very elegant study based on both animal and human tissues. Now, the important question is, since we are clinicians and scientists, and we now know that some of these diseases have a causal effect, or at least contribute to the pathophysiology, so will manipulation or modulation of the microbiota improve pancreatitis and pancreatic diseases? So how to go about it? We can use the bugs as drugs, FMTs, probiotic, prebiotic, symbiotic, enzymbiotic, many biotics are coming up. We can drug the bug by phages, by specific antibiotics, antifungals, or we can make drugs out of the bugs. So let us see how to make the bugs as drugs. And this is the most common thing that is going on. We all talk about probiotics and FMTs and prebiotics. So let's see some of the results in acute pancreatitis. And only in acute pancreatitis, actually, these kind of studies have been done so far. And if we see here, 7 studies, all randomized controlled studies, but heterogeneous results. So some of the studies actually should, you need not see the whole slide, it's a complicated slide, just see this column. Yeah. So in 3 of the studies, there was no difference. In 3 of the studies, there was some difference. So there is heterogeneity. And in one of the study called the ProPatria, there was actually increase in the death in the treatment arm. More patients than the study had to be withdrawn early. So why is it so? And I think here we have a problem, because all these treatments are, I'll just take another 2-3 minutes. So most of these studies are done with the presumption that we have a normal gut microbiota. And rightly so. There are studies from all over the world. Every country has a individual microbiota. We have shown that the Indian microbiota is more predominant in Faecalibacterium and Prosnit and Prevotella. But the problem is these samples were collected at a single time point. If we look at more recent studies, that shows that there is significant temporal variability in this organism. Even in the same day, there will be diurnal variation in the bacteroidetes and the firmicutes ratio. So this shows that 78% of the microbial genera are substantially higher intra-individual variability. There is significant fluctuation in diversity even in the same day, and variations occur around an equilibrium. Same thing happens, and that is regulated by whatever you are eating on that particular day. It's very diet specific. So if you are eating something today, we might have a different microbiota. If we eat something else tomorrow, we might be having a different microbiota. So that variability probably impacts how the intervention works, because the same thing will also happen in the pathogenic microbiota. And that is why probably there is diversity in the effect. So the problem here is when we give probiotic, it's a very narrow spectrum. We give some strains of lactobacillus and few other strains. And with that, we try to fight against a huge gamut of huge ecology where there are millions of organisms. That's why I think we need to use new generation probiotics. We need to have more Akkermansias, Prevotellus, Faecalibacterium, but unfortunately, most of them are unculturable. Now, there are some studies where some strain of Faecalibacterium can be cultured. Akkermansia is available in the market. The other thing is we always talk about probiotic effect on the patient. But what is the resident microecology of the patient doing to the probiotic or doing to the FMT for that matter? We do not know what is the interaction of the ingested probiotic with the food taken on that day. So all these are, I think, hurdles, and these are the important things that needs to be addressed. And this is where the young mind sitting here can think of and make a career out of that. So again, importantly, it's not about the single bacteria that works. So if you see individual studies, there will be the results are same. They will say the pathogenic organisms are increased. This is high, this is low. But if we talk about individual species, they are not same in their studies. Why? Because the organisms work as group, and that is where the concept of enterotypes, groups, cluster come in. And then these actually produces metabolites, and we actually have a functional metabolomic core rather than the functional bacterial core. And that is why I think treatment should be targeted using metabolomics. Right? Use the bacteria. You can have this could be the future bioengineered commensals, where you can engineer them to make some specific metabolites. We can use direct metabolites like butyrate supplementation. We heard about retinoic acid. We can use combined personalized consortium of bacteria and metabolites. I think this is the direction which we need to think of rather than just giving a small strain of bacteria or a fecal microbial transplantation. And even in dietary intervention, we all talk about diet, which is important. Again, how much does it work? We never talk about the food matrix. We never talk about the resident microflora. Is it permissive? Is it restrictive? We don't talk about the timing of intake, circadian rhythm. All these things would also impact the effect of diet on microflora. So these are the things that needs to be considered in this kind of interventions. So I'd like to conclude here by saying that gut microbial dysbiosis in pancreatic disease is real. It could have causal association with few of the diseases, but most importantly, we need to have higher quality, robust mechanistic studies and clinical studies to evaluate the effect of modulation in terms of metabolomics and a group microbiome, not just one or two organisms. And I think I'll stop here by acknowledging a lot of people who have been working with me. And thank you. I'd be happy to take questions.
Thank you very much. That was a very thought-provoking talk. So can we have a couple of questions? We are again short of time here, but we definitely, this talk is going to raise more questions.
Really, Dr. Talukdar, congratulations. This was a marvelous talk.
Thank you, sir. Thank you.
And my comment is that all these three talks could be very interesting to critical care people also,
Yes.
because many of them go
Yeah.
to septicemia,
Yes.
ICUs, and they would have benefited tremendously. What I find important is that we also do the same thing now, that we look at the fungi,
Yeah.
we look at the anaerobes, and we look at the viromes also,
Right.
because each one has got a function.
Exactly.
The viromes can depopulate one,
Right.
and fungomes through their metabolite,
Right.
and through some of the critical elements can make these brush border
Yes.
much more
Yes.
amenable. So this was the first time I saw the intestinal villi.
Yeah.
And this is the first time
Yes.
that you were able to do it. I
Yeah.
hope that your ethics committee had allowed this.
Yes.
But this is a very
You had to.
important data.
Yeah.
So my ultimate suggestion is this, that most of these metabolites or metabolomes could be countered.
Right.
And the whatever interventions we do, these metabolites could be countered through chemical entities.
Yes.
And we should also put this in our plan.
Right.
But wonderful talk.
Thank you. And what I think we should be doing is, in all these studies, at least fungome or virome, because phages are very important. And we do not, when we see the bacterium, we don't talk about fungome or the virome. So all three should be done together, but the hurdle is cost. I mean, with high cost, we cannot have good sample size. We need big sample size with all. So that's the biggest hurdle, I think.
Professor Rupjyoti, Dr. Ajay Bhalla, I'm a gastroenterologist. Yeah. Excellent talk. I just wanted your one straight answer, because you presented a very nice detailed study where probiotics, whether used prophylactically or later during the course of acute pancreatitis, did not show any improvement in severity of disease, did not help in prevention. Rather, Besseling's study talked about increased risk of death. So in this current day, would you still recommend using probiotics, or you do not?
At least in acute pancreatitis,
contraindicated, or would you like to time it somewhere?
So at this point I won't, but I'd like to see more studies where we could conclusively show that, okay, if we give this, these are the hard clinical outcomes with a benefit, with a side course benefit. So then maybe, but I need more studies.
So current message would be in acute, severe acute pancreatitis, do not use
At this point, no. Maybe 5 years from now, we may have a different answer.
Thank you.
With that, I think we come to the end of the session.
Thank you.
Thank you very much again. And can we have a big round of applause? So I think it's been an interesting session talking about the gut microbiota, fecal transplants, and pancreas and gut microbiota crosstalk. And I think we probably are heading in the future times, probably we'll have more and more of this we'll see in clinical practice affecting our AMR rates and our clinical practice as well. Thank you very much.